I would like to inform you that this presentation is recorded, and for us to have a very good experience, these are some of the housekeeping rules that we need to adhere to. Number one, please ensure you have a very good network. Number two, ensure your device is good, especially your two pieces. I call them two pieces. That's your earpiece and your mouthpiece. And then you have all been muted by the hosts. This is just to avoid background noise. When it's time for contribution, you can use the raise hand button. If you have any contribution to make, the host will ask you to unmute, then you can now speak. And once you are done speaking, please do not forget to mute your microphone. Comments in the chat box, because of the moderation, I might not be able to read them until the end of the whole session. So I'm very sorry about that. So it's not that I'm ignoring the chats, but I might not have enough time to be going through them, but I will surely read them. Or if there is anyone that needs me to act on anything, I will surely do so. So those are the housekeeping rules. And without wasting much time, I'm going to be introducing our lead presenters, Dr. Olubenga Alabi from the Faculty of Medicine. Dr. Benga Alabi is currently in the United Kingdom. He's also practicing in the UK. We were together in the UCH some time ago, but as God will have it, he has left us for the United Kingdom. He's one of the best brains I've ever come across. He has this common name that we all know, that's Chromo, that is a very common name, and then he's one of the best as far as this field of medicine is concerned. And he's an alumnus of Alabi Onabanjo University, and a proud one for that matter. And I'm very, very glad to have him around today. So he's going to be representing the Faculty of Medicine, and he's going to be telling us his own point of view as far as the case we are going to be presenting tonight is concerned. Our second presenter who will be taking over after Dr. Alabi is Dr. Musa Muslima. She is a colleague, a senior registrar in the Department of Radiology, University of Ilorin Teaching Hospital. She's one of her kind. She's highly cerebral radiologist, and we are going to actually agree with me by the end of this presentation. She's also she's an alumnus of University of Ilorin, and a proud one for that matter, Better by Far University. And I think that's all. I've introduced myself. I'm very sure all of you know me already. I'm the admin of Doctors Assembly, and I won't want to waste much time. I'm going to stop sharing my screen and call on Dr. Alabi to please come on board and share his screen so that we can begin straight away. And again, please, before I off my mic, I would also like to appreciate the presence of Dr. Tafazua. If I call it correctly, I'm very sorry. He's a very good friend from Swaziland. You are welcome. Also, I would like to announce, just as I've said, that somebody donated a cash prize for anyone who could clinch the diagnosis for tonight's case presentation. So I will be here. If you have anything to say, just raise your hand. And if your contribution, if your diagnosis is very close or you hit the nail on the head, the money might be yours. So thank you once again. I wish you happy listening. So Dr. Alabi, over to you, sir.
Thank you. Good evening, my senior colleagues, my colleagues. It's an honor being with us this evening. to discuss this case. It's a case of a 26-year-old female, and the case has been earlier put on the platform for us to read over. It's quite a lengthy one, almost 3 pages, but myself and Dr. Lee have been able to bring out the salient features, and which I will just share now. So, okay. Can we see the screen now?
Yes, we can.
Okay. Once again, I'm Dr. Alabi. I'm representing the Faculty of Medicine of the Doctors Assembly. And this will be the outline of my presentation. The case is that of a 26-year-old female who presented at the emergency department because of headache, and she's got background history of headache. So the new headache she has seems to be a new one, and she had multiple history of travels to different areas. She traveled to Europe for about 3 weeks before presenting, and 9 days before that time, that was within the last 21 days, she visited the mountainous aid region, and she stayed in the mountain cabin, spent a few times in the snow. And from the history, we were told the cabin is as high as 3,400 meters above sea level, which puts her to an increased risk of having high altitude cerebral edema. And while in the mountain, she had a mild trauma to the head from a low velocity sledding accident. And she had headache then. Remember, she had background history of migraine. And this lasted several hours and resolved spontaneously. Now, with the new headache she had, and also the high altitude where she was, the diagnosis of a likely acute mountain sickness is very likely in that case. And this usually occurs within 2 days of flying above 400 meters, although this is not up to 400. And there are several risk factors: exertion, the rate of ascent or descent, and lack of acclimatization. And classically, they present with headache, difficulty in speaking, loss of consciousness, nausea and vomiting. In our patient, she had only headache. And in this case, when we give the carbonic anhydride inhibitors, give steroids, supplemental oxygen, there's usually an improvement. Now, 8 days before presenting to the ED, she had a form of severe headache, which she described as the worst headache of her life. And most times they say that this sometimes may qualify to what we call thunderclap headache. And there are so many causes of thunderclap headache, but one of them is a subarachnoid hemorrhage. And when we have patients presenting with this, we may have to look for red flags in them. Now, classically, using the Socrates of the pain was that the pain was located in the bitemporal regions and occiput, and it was sudden in onset, and she described it as the worst of her life. That was different from the background migraine she had. And she said it radiates to the back, to the occiput, and she had restricted fatigue, nausea and vomiting, neck stiffness with decreased range of movement, which is quite important. And she had some mild chills and cough. She was admitted and given some IV fluid and analgesic, and the headache persisted before, and this warranted her moving down back to the US probably for better care. And there was no known significant aggravating or relieving factor, as she got no relief from the analgesic she had, and she described it as 10/10. Now, before coming to the ED, with this severe headache, she had photophobia and sonophobia, and she also had a weak history of intermittent fever, chills, and night sweat. These are pointers to encephalitis. Remember that she's had neck stiffness, headache, and fever now, and chills and night sweats. These are pointers to encephalitis or meningitis. And this is included. We include TB meningitis in her because of the night sweats and chills and others. Now, she also had constipation for a few days, and the examination vital signs were fine, and there was no neurologic abnormality, and she was discharged home on analgesic. Now, in this in-depth presentation that warranting her admission, so this headache has been something recurrent. She is also a severe form of headache, and there was associated nausea and vomiting. And with no history of weight loss, no sore throat, no shortness of breath, no cough, no chest pain, no dysuria, and she has no rash. The absence of rash makes it very unlikely that she will be suffering from meningococcal meningitis. However, the absence of history of weight loss others also, and there are also no mucocutaneous ulcers. And there was no similar symptoms of all these conditions in a family who traveled together. Now, the share history is that she immigrated to the US more than 15 years ago. She was originally from South America, and we know that South America have some common fungal problems that common to them. And she's married and lives with her husband in a suburban region. She works in the healthcare industry. No history of STI. She has a vaccination up to date, and she had exposure to varicella infection as a child. That's also a very important history. She also traveled to Canada and Mexico a year ago, and she has a healthy dog. And having a healthy dog, we have to consider rabies, canine distemper, encephalopathy, encephalomyelitis in her. But we know that the mortality of rabies makes it very unlikely that, because if she had presented with rabies encephalitis, it's likely that the mortality is 100% and will have had the history of the history that probably she died. I don't know what ended the case. Now, there was history of exposure to rodents, and we know that rodents are reservoirs for leptospirosis, which is a form of spirochetes, and common in the mountain cabins where she stayed. And there was no non-animal exposure of tick bites, and absence of tick bite makes infection by Borrelia burgdorferi very, very unlikely, and also a Rocky Mountain spotted fever ruled out. She takes alcohol in moderation and does not smoke or use illicit drugs, and other family members are healthy. So on examination, vital signs were fine, and there was full range of movement of the neck and mild pain in the posterior cervical region on flexion. And there were no oropharyngeal ulcers or rashes, and the rest of the examination was normal. She has blood done, and blood showed normal electrolyte and renal function test. And as part of our differential, we know that in patients who have leptospirosis, they usually have some degree of renal failure. So that will be evidenced by probably elevated urea and creatinine. But in her, it came back fine. So it's still very unlikely that it will have been leptospirosis despite exposure to rodents and the likes, because we know that leptospirosis is usually transmitted via feces of rodents and more of a fecal oral route. Now, she had multiple markers done. ANA came back negative, which rules out either an inflammatory process or rheumatoid arthritis. SLE is very unlikely. She had a P anchor coming back negative, and all these rule out CNS lupus or autoimmune vasculitis. And she had a WBC count and CRP are within normal range, and this makes it very unlikely that the process going on in her is an inflammatory process. And with neutrophils still within normal range, it's very, very unlikely that it looks bacterial, because we know that in response, if it were to be a bacterial problem, we know that we should have neutrophilia. And she went ahead, we have a normal C3, C4 level, and we know that these markers, these complement factors are decreased in patients who have immune complex disease, still SLE, vasculitis, the cases of IgA nephropathy and the like. So, and in this case, the patient have low normal C3C4. We should, however, note that in the Listeria monocytogen, C3 may be low with normal C4, because this Listeria monocytogen is also a very important differential in this patient, as we'll see in the CSF finding. Sorry about that. Okay. So the patient had the pregnancy test done, which came back negative, and she had multiple heterophile antibodies done that to rule out some other common viral etiology, such as EBV and infectious mononucleosis, but all came back negative. She also had screening done, and came back negative, even going as far as doing an RNA of HIV. And then we know that immunosuppression is a risk factor for some common diseases, such as progressive multifocal leukoencephalopathy, CNS CMV, cerebral toxoplasmosis. But if it were to be cerebral toxo, I know that the radiologists will definitely pick this on the you should see it on CT, where we have I think this ring enhancement or whatever they call it. I think my colleague in radiology will assist with that. And then she had a urinalysis done, some leukocytes, blood, and some ketone. But the specific gravities came back normal. Now, with all this, we've been able to see that we've ruled out so many inflammatory causes. We've tried to rule out some viral etiologies, such as EBV, CMV. Now, we went ahead and did an influenza, RSV, and others, and all came back negative. Now, for Lyme's disease, despite having a vaccine and having a dog, is also it's something we should consider. Maybe she was bitten by tick, and the Borrelia burgdorferi and syphilis came back non-reactive. So hence, it's very unlikely she had Lyme disease or a neurosyphilis causing the headache. And because of the initial place where she came from, South America, and we know that some of these fungal agents are quite common in that area. An example is the coccidioidomycosis, paracoccidioidomycosis, and all those, they are basidio stuffs, the fungal problems. But they all came back negative, and that rules out what looks like either an invasive or cryptococcal meningitis or invasive candidiasis. Now, imaging was done, and the only finding were that she had multiple enlarged lymph nodes on the neck, and the MRI with gadolinium enhanced came back normal. So that's very unlikely that she had some neuroinflammatory or some degenerative CNS disease. And chest X-ray also came back normal. Now, the differential diagnosis of the only abnormality that was seen on the MRI was, and the CT was the cervical lymph node being enlarged. And I have some of these differential, either a bacterial infection in which there will be a reactive lymphadenopathy, and usually I expect it to be tender a bit, and viral infections such as EBV, HSV, CMV, and the likes. Now, tuberculosis is also very likely, as she has lived her life for some time in South America before moving to the US, although this infection seems to run a subacute course, because it's all occurring within 21 days, while for TB is expected to run a chronic course. However, we still consider a TB meningitis with tuberculous cervical lymphadenitis in this patient. And then there are also non-tuberculous mycobacterial cervical lymphadenitis. Now, because of the neck stiffness, headache, fever, she had, and the CT coming back negative for any major intracranial pathology. She had a lumbar puncture done, and this gave so many information that would make us hit the diagnosis. Now, but I want to review the blood, full blood count is as shown. Normal hemoglobin, hematocrit is fine, platelet count is normal, white cell count is within normal range, and the differentials look good. And then the CRP, ESR, all are within normal range. So that rules out something of an inflammatory origin. However, the CSF findings showed that it was colorless and slightly morbid. And the glucose was low. So there is hypoglycemia with markedly elevated protein. And the cell count too was also, red cell count is 4, and the total nucleated cells was 1,422. And that's the WBC count with predominant lymphocytosis. So patient had pleocytosis with lymphocytic pleocytosis, which has some common differential. And the absence of xanthochromia makes it very unlikely that the patient has suffered a subarachnoid hemorrhage. Though even if she described the headache as the worst headache of her life, the absence of xanthochromia, and some will even go further to do bilirubin or oxyhemoglobin, rules out a subarachnoid hemorrhage. Now, what are the differentials of a pleocytosis, raised nucleated CSF? We have viral meningitis, meningoencephalitis, or aseptic meningitis. TB meningitis is also common. Syphilis, multiple sclerosis, brain abscess, and brain tumor. And we know that the brain tumor will have been ruled out with the MRI and the CT, and also a brain abscess. We know for brain abscess, they have the ring enhancement with very something edema and the likes. The multiple sclerosis, definitely we know of Dawson fingers, where we see some of these demyelination appearance. And then syphilis, the patient that had the blood done, which came back negative, so that rules it out. And then TB meningitis is also likely. However, we know that TB meningitis will run more of an indolent or a chronic cause, and most times the patient will usually have a cranial nerve defect, and because the tuberculoma or whatever that is formed usually settle at the base of the skull, where we have the cranial nerves originating. So therefore, when this patient, the cranial nerve examination came back fine. Viral infection is also very likely, or episodic meningitis. We'll see that in this patient that had multiple viral investigations done, which ruled out so many viral infections. And this is just like a summary of the interpretation of the CSF. We see that in viral meningitis, they have a normal appearance. CSF is usually raised, normal blood cell count, protein may be high or normal, and glucose may be normal or low. And then in bacterial meningitis, we know that CSF can be cloudy or turbid, and then neutrophil count is markedly raised. So they have there's marked neutrophilia within the CSF, but in this case, they are more of lymphocytes. 85% is lymphocytes, so that's quite massive. And the CSF finding has been able to support us to narrow down the diagnosis to like 2, viral meningitis and tuberculous meningitis. However, there's a form of bacterial meningitis, the Listeria monocytogen, which may also have they may have they may have raised lymphocyte counts within the CSF. However, we know that with the C3, C4 being normal, it's very unlikely that the patient will have had a Listeria monocytogen infection. And also by epidemiology, we know that Listeria monocytogen is most commonly affects children and not the adult using epidemiology. So the patient was treated with vancomycin, ceftriaxone, acyclovir, ampicillin, and given so many things. However, if this had been a bacterial meningitis, it's very unlikely that the patient may have responded to vancomycin, ceftriaxone, ampicillin, and the likes. And with the administration of acyclovir, acyclovir is commonly used to treat HSV meningitis. And we know that if this patient had suffered from HSV meningitis, they usually have some frontotemporal abnormalities. They may have hemiparesis, they may have amnesia, they may suffer seizures, and most times the MRI will not miss an HSV encephalitis. They have these lesions within the orbitofrontal and the temporal region. I think I saw some like 2-3 weeks ago. So this makes it very unlikely that it's HSV, and maybe that was why the patient did not really respond to the treatment. Now, I'm narrowing down the differentials to a tuberculous meningitis, a viral meningitis, or encephalitis. And this is based on the history of headache, mild chills and cough, and then the intermittent fever, chills and night sweats, and some degree of some meningeal signs. And the history of travel to Mexico, which may be endemic for TB. And then the CSF finding. And we should know that although the CSF the gram staining for the CSF showed no organism, we may miss TB in the CSF if we've not taken enough sample. We'll see that some have said you need to take enough volume of CSF for you to be able to pick the mycobacterium within the CSF, and then we know that gram stain will not really pick up Mycobacterium tuberculosis. We'll rather either do a ZN stain. And most times, if we give the standard antibiotics, they don't really respond in TB meningitis. And this patient, we know that TB meningitis is quite common in the immunocompetent, but this patient in the immunosuppressed, sorry. However, we may see it in the immunocompetent. And according to Walker et al., the fact that you've had a BCG vaccination does not make it will only give you a partial protection. Does not rule out the fact that a vaccinated individual will not come down with TB meningitis. And in TB meningitis, I expect other very severe presentations, such as drowsiness, confusion, visual impairment, cranial palsies, and seizures, as I've said. But this patient looked, from the history, looked fine. Though the patient is sick, but looks fine, not critically ill to really go ahead and get a diagnosis of TB meningitis. And these are the stages of TB meningitis. In the early stages, they may not have any alteration in the level of consciousness, and it can progress to utter consciousness without coma and delirium. Or lastly, if it's in stage 3, they can have stupor and that. Now, in TB meningitis, we know that CT and MRI, they lack specificity and the likes, but we are certain that if we're able to pick their bloods, we may have elevated CRP, ESR, and WBC count. But in this case, it's quite normal. And the serum glucose in the CSF is not really very low in TB meningitis and viral encephalitis. And we know that for any of these brain issues, either overtreatment or undertreatment may predispose them to having hyponatremia, which can be seen in like 45% of patients. And doing a lumbar puncture in TB meningitis, the likelihood of picking TB, the bacterium, is just 50 to 80% of cases, and we may need to do a PCR for a rapid and reliable diagnosis of this, but we may also have a false negative result, and I mentioned ZN earlier. Now, the diagnosis of TB is established by observing the bacterium in the CSF, if we are to make a diagnosis of TB meningitis, and the yield is more than 50% in large volume tab. That means that we must have taken like 10 to 25 mil. And I know that most times we will not want to go that high. And we may culture it, but the yield is low. And PCR is also a very important testing. And we know that the treatment will be to give the rifampicin, isoniazid, paracetamol, and ethambutol for 2 weeks, and then the last two for under 10 months. And so my differentials now are one. I think this patient has an aseptic meningitis with likelihood from maybe an erena viridis, but I'm not sure of the one it is. And this is because of the evidence of rodent around the mountain, and it's common in adults and during autumn and winter. And this patient had features of upper respiratory tract infection in the early stage, flu-like symptom, then headache, and there was no significant response to antibiotics. That makes it very unlikely that it's viral. And varicella zoster is also a likelihood, and this is because she had a previous infection. She may have a reactivation, but I expect that she will have a classical dermatomal rash, and which is absent in this patient. TB meningitis, as I've said, leptospirosis is also very likely. However, in leptospirosis, I expect some degree of derangement in the U and E, which is not in this patient. And listeria is also common. They also come down with lymphocytic pleocytosis in the CSF, but with the normal CPC4, and we could not isolate listeria. Listeria seems to be a gram-positive bacteria, so not isolated. Mumps is also very likely. Mumps encephalitis is also likely in this patient, but this patient is said to have been fully vaccinated. And although fully vaccinated, in mumps encephalitis, they also come down with very high amount, very high CSF lymphocytic pleocytosis and hypoglycorrhea. But with that vaccination, I'm trying to hold back a bit. And then I expect that the patient may have maybe mumps a parotid swelling, and maybe even either mumps, if it were to be male, they have mumps, mumps, what's this thing, the swelling, the painful swelling of the testis called, and then in females, maybe ophoritis. And I made this table to show the likely diseases that are transmitted by rodents, and antipulmonary syndrome, which is not likely. Then hemorrhagic fever, the patient did not have any hemorrhagic features or renal problem. Lassa is also not likely. Leptospirosis, I've ruled it out. And I'm not, this is also very hemorrhagic, which I'm not, this patient will likely not have it. So I'm left with what looks like maybe a lymphocytic choriomeningitis virus, I don't know. And it's said to be a form of arenavirus. And why I said that is transmission is also through rodents, as I've mentioned, and treatment is not really is supportive. So most times, even if you do everything, they may come, it runs its course, and some have tried the barbarin with little response, and I never had it mentioned in the history, either it was done or not. So I want to acknowledge Dr. Lea Ajayi for the initial slide presentation on our page, and then the chief admin and all faculty of medicine members. These are my references. Thank you.
Thank you very much, Dr. Alabi, for the wonderful presentation. I won't to waste much time. We move, please, can you please unshare? Dr. Musa, please, you have the floor. Please, let's hear the radiologist point of view concerning this case. Thank you very much.
Okay, good evening, everyone. Standing on the existing protocol, I'm Dr. Musa from Radiology Department, UITH Ilorin. I'll be talking on the radiological investigation of this patient. Okay, the radiological investigation done by this patient as CT, CT angio, and MRI. So on the computed tomogram, the report was that there was no intracranial hemorrhage, no infarction, and no mass lesion seen. And on the MRI too, there was no abnormal parenchyma, pachymeningeal or leptomeningeal enhancement seen. However, on CT angio, there are multiple cervical lymphadenopathy seen. On the A panel A, there is an arrow pointing to the upper jugular lymph node, the enlarged upper jugular lymph node. Usually on CT, the lymph nodes appears as soft tissue lesion that does not enhance. So we have the blood vessels here that has contrast medium within it, and then the lymph node, the enlarged lymph node here. On the panel B, it shows the left submandibular lymph node enlargement, while on the panel C, point to the right spinal accessory lymph node enlargement. So the cervical lymph node enlargement, usually the cervical lymph nodes are grouped into, they have their groups. So the submandibular lymph node that's enlarged, it's on group 2B. The upper jugular lymph nodes on group 3. The spinal accessory lymph nodes is group 5 cervical lymph node. The important negative, the other positive has been highlighted by the first presenter on the CSF findings. So the important negative that will help with the differential diagnosis, first one is the serum cryptococcal antigen that was negative, and the nucleic acid testing for influenza A and B viruses and respiratory syncytial virus are also negative. So from these findings, my differential diagnosis, the first one I would like to go for is lymphocytic meningitis, most likely chronic, because of the appearance of the CSF. One, the CSF appears cloudy, there is reduced, glucose level is reduced, and the protein level is increased. Also, there are mononucleated cells, which is predominantly lymphocytes. But on the other hand, radiologically, there is no we expect to have a meningeal enhancement, though it could be it's absent in this patient, which which is the reason why I'm thinking it could be a chronic lymphocytic meningitis that has been on for a while. That's why there's no meningeal enhancement in this patient. Then my second differentials is CNS lymphoma. Usually we have the primary CNS lymphoma or the secondary CNS lymphoma, and most often CNS lymphomas are the non-Hodgkin type. Why I'm going for this is because of the spinal accessory lymph node that is enlarged in this patient. Usually the spinal accessory lymph node are usually involved in metastatic involvement. They are usually involved in metastasis. So probably this patient has an ongoing metastasis, ongoing malignancy that is going on, either a primary lymphoma that is going on, which now metastasized to the cervical lymph nodes. Then my third differential is varicella zoster virus encephalitis. The reason why I go for that is because the patient will have a reactivation of the latent infection that she has during childhood, though on the which this can still be in keeping with the CSF findings that we have. Then my other differentials is the tuberculous meningitis. But in this patient, like I said, the important negative, the chest findings, the patient, there's no findings on chest, and the patient is also said not to have any complaint of, there's no cough, though the patient has night sweat. There was history of night sweat in this patient. Then the other findings that are not in keeping with meningitis has been highlighted by the first presenter. But radiologically, we expect to also have meningeal irritation, which this patient also does not have. Then in CNS lymphoma, sorry, I forgot to mention, in CNS lymphoma, most often radiologically, there's usually solitary lesion involved. But this patient does not have that, aside the lymph nodes that it's enlarged, which is highly in keeping with metastatic spread to the cervical lymph node. Then my other differentials are the bacterial meningitis and the bacterial meningitis and fungal meningitis. But like I said, for the viral meningitis, we expect to have meningeal enhancement in this patient, of which the MRI did not show any meningeal enhancement, and there's no focal lesion noted within the brain parenchyma. So in conclusion, my first differential will still take a hold, which is the lymphocytic meningitis, then followed by the CNS lymphoma. So in this patient, most likely I will advise a biopsy for us to know the cells involved in the biopsy of the enlarged lymph node to conclude at the diagnosis. Thank you.
Thank you very much, Dr. Musa Muslima, for the wonderful radiological summary. Without wasting much time, I think please kindly unshare so that I can share the final answer. I'm very sure, but before I do that, I'm very sorry. I would like to hear from the audience. Just as I've said, I've not changed the rule. The closest to the diagnosis gets a prize. So if you have anything to say, just click on the raise hand button. I'm going to give you the mic to, yes, I can see some hands now. Okay, so Dr. Ridwan Adegboyega, you have the floor.
All right, thank you for the opportunity, admin. And it's been a wonderful presentation. I could hardly think over it that amongst us we could actually dissect it and small, but I'm quite impressed. So yes, my contribution is this. One, I think there's history of fever, headache, neck, and then neck stiffness in this patient. So meningitis comes up for me. So is it bacterial, viral, autoimmune, TB, fungal, or plastic? The presenters have done justice to that. Bacterial, not likely because patients will be more toxic, and then CSF would support more of neutrophils. Of course, there can still be a lot of proteins and then reduce glucose. But we don't have that picture. This woman was essentially having at a point 36.1 and the likes. So fungal infection too, usually in the case of immunosuppression, and the commonest type we usually come across, especially in HIV patients, is the crypto, which I think an Indian ink should pick. And the CSF picture is not classically as well as presented. TB too, as rightly said, though this patient had some lymph node enlargements, and like Dr. Kromo rightly said, about 30% of them may actually miss the typical chest findings amongst other things. But I did not see anything like weight loss. Usually TB is usually more chronic than that. Night sweat, hemoptysis, and most importantly, I was expecting the ESR to be markedly elevated. I think what I saw was about 5 or so. Autoimmune, almost all markers were essentially normal. And then for the viruses, I think that is where the meat of the discussion has been. The first and second presenter have said they support, especially the arenaviruses. I also go in line with that thought, especially with some other things which I'm not sure if I heard, or perhaps it was just mentioned maybe briefly. This woman had a kind of biphasic nature of the disease. She went on break in the mountains. Then I think about 8 or 13 days, maybe I think that was what I saw. She started having all these headaches. and she was relieved. She was discharged just to come back. So I think it's classical for this lymphocytic meningitis, that the patient would usually after a week or two, patient would have symptoms. It could be mild, it could range from headache and the likes that she had. Then there will be a rest phase, and then they'll go into a second phase where they then have this CSF picture, which Dr. Promo also rightly said, mumps could also give us that, but I don't think mumps has that biphasic nature. So just in addition, I think, yes, she went on break, perhaps got exposed to the excreta or urine of mice when she hit her head. And then she had this biphasic nature of the disease, which essentially more or less did not go with any medical treatment. Perhaps it was just self-limiting, but other things that were given were just to cover the more serious illnesses that could be present. In case of herpes simplex, which could be very deleterious if possible, listeria, which you are covering with ampicillin, amongst others. So I would say yes, that I'm going with what the presenters have said, which is a lymphocytic meningitis. Thank you for the opportunity.
Thank you very much, Dr. Ridwan Adigwega, for the deposition. I've noted your differentials, and I have not seen any other hand. Any other person? Please, just let me see your hand, then I will ask you to unmute. I would like to hear from a number of people, at least what you think about this, this case. It's quite an interesting one. Before I now read out the final answer, I have the final answer, so don't worry. So I think that's all that's all that we are going to have for tonight. So let me share. So this is the verdict. So this 26-year-old previously elderly woman with a history of migraines presented with an 8-day history of severe headache that developed during a winter vacation in Europe. On presentation to this hospital, she described the acute onset of the worst headache of my life. Moreover, her headaches had been progressive, ongoing, and unresponsive to medications that had typically been effective in treatment of her migraines. So she reported systemic symptoms, including fever, chills, night sweats, and neck stiffness. Her CSF studies were consistent with meningitis, yet she appeared clinically well. Given that headache and meningitis were the most prominent features of her presentation, I will construct. Headaches are common, and clinicians must therefore be attentive for red flags, the red flag signs and symptoms that warrant a more in-depth evaluation. This patient's progression and severity of the headache, lack of response to treatment, and systemic symptoms were a red flag that led to the clinicians to perform the lumbar puncture that revealed the abnormal CSF findings. The initial most important action was to assess whether treatable causes of acute meningitis, such as bacterial or herpes simplex infection, were present. Since treatment delays for such infection may lead to clinically worse outcomes, so it is appropriate that we should consider initiation of empirical antibiotics until the data are available to help us rule out other diagnoses. So I will start with bacterial meningitis. You will agree with me that approximately 95% of patients with bacterial meningitis will present with at least two of the following of the four symptoms: headache, fever, neck stiffness, and altered mental status. These patients had three of these four symptoms. However, unlike these patients with bacterial meningitis, just as Dr. Ridwan has said, they are quite ill appearing, they are toxic, and they present soon after the onset of symptoms. In addition, although a predominance of lymphocytic cells in the CSF can occur early during the clinical course of acute bacterial meningitis, neutrophils neutrophilic pleocytosis is more common. This patient's clinical presentation, negative ground stain of the CSF and lack of neutrophils in the CSF make the diagnosis of acute bacterial meningitis very unlikely. HSV encephalitis, although it can cause both meningitis and encephalitis, but HSV encephalitis can be very fatal and can be manifested by features that are clinically similar to those of acute bacterial meningitis, such as rapid onset and marked severity of headache, fever, and focal neurologic signs. So HSV encephalitis is usually associated with a frontotemporal sign like behavioral changes, amnesia, aphasia, seizures, and hemiparesis. But in these patients, in patients with encephalitis, MRI characteristics are usually that of a signal hyperintensity that you see at the orbitofrontal and temporal lobes. Now, these clinical and imaging findings are not present in these patients, just as Dr. Muslima has rightly pointed out. In addition, a highly sensitive and specific HSV nucleic acid test was also negative, making the diagnosis of HSV infection unlikely. Other causes of meningitis, after evaluating whether common treatable causes of acute meningitis are present, the workup for meningitis can now focus on differentiating among other possible causes. Now, please, I would like us to note that the time course, the illness trajectory, and the clinical syndrome, including findings on physical examination and laboratory testing and imaging, can help direct our workup. And it is also important to consider patient-specific characteristics like the age of the patient, the immune status of the patient, and exposure history. Specifically, exposure history. Please note it, specifically exposure history, which should include the time of the year, the travel history of the patient, sick contact, insect bites, animal contacts, medications, and substance use, just as Dr. Alabi has done a very beautiful job in trying to rule in and rule out some of these things. The first, under the viral causes, are the enteroviruses. I took this because they have, but usually the enteroviruses, they have higher incidence during summer and autumn, and they are transmitted from person to person via fecal-oral routes. Lymphocytic pleocytosis is a characteristic of enteroviral meningitis, but this patient presented in the winter. That's one minus, and had no known history of contact with sick persons. Patient's high number of lymphocytes along with high protein level and low glucose level will be atypical for enteroviral infection. Then the next one is VSV, that's a varicella zoster virus meningitis. It is more commonly associated with reactivation of varicella zoster virus. Even in the absence of cutaneous lesion, this patient had chickenpox as a child, which places her at risk of reactivation. However, our CSF findings were atypical for varicella zoster virus. The next one is HIV. In this case, the patient had negative screening test for HIV antibody and antigen, and undetectable blood level for HIV RNA viral load. So this rules out the diagnosis of chronic HIV or acute HIV infection. Other viruses that you might like to consider: the West Nile virus, the St. Louis encephalitis virus, the Toscana virus, the tick-borne encephalitis virus. Now, because this patient lives in northeastern United States and has traveled to Europe, she is at risk of infection resulting from these viruses that I've mentioned above. The incidence of these infections are usually highest in late summer and early autumn, consistent with peak seasons for mosquito, sandflies, and tick vectors. Therefore, given the patient presentation during winter and a low risk to exposure at this time, these diagnoses are unlikely in this case. Furthermore, patients markedly elevated CSF lymphocytes, high protein level, low glucose would also be atypical for this viral infection. Then TB meningitis is more common among patients that are immunocompromised than among those people that are immunocompetent. And it generally leads to this chronic progressive form of meningitis. Moreover, our patients Patients with meningitis characteristically present with neurologic features like confusion, lethargy, cranial nerve deficits. These are findings that from the history, the patient doesn't have any of this. So TB meningitis is very, very unlikely. So TB is down. Now, spirochetes like Treponema pallidum, Bordea, Bogdoferi, and leptospirosis. Now, this patient had no history of rash or other clinical findings consistent with this infection. Now, Lyme disease usually occurs during 1 month when ticks are very active, and the patient did not report any known tick exposure. In addition, in this case, the tests for syphilis, Lyme disease were both reportedly negative. Then leptospirosis, you can see in green that the patient has exposure to rodents, which are an important reservoir for spirochete leptospira. Although leptospirosis has been noted in parts of Europe, it is more common in tropical climates and is often associated with exposure to fresh water. In addition, this patient did not have any other systemic features to suggest leptospirosis, and these are the conjunctival suffusion, rigors, myalgia, jaundice, renal failure, as we have seen in the renal function test that everything comes back negative, making this diagnosis also unlikely. Then the fungal ones, that's Coccidioides immitis and then Cryptococcus gattii. The Coccidioides is endemic in desert region of southwestern United States and northwestern Mexico. Now, this patient traveled to Mexico in the year before presentation. So these potentially places are at risk of this fungal infection. Now, coccidioidal meningitis may manifest with eosinophilic pleocytosis in the CSF, although it is typically associated with the presence of lymphocytes. So actually, we need more history about our trip to evaluate our risk further. Now, the Cryptococcus gattii, the reason why I'm considering this is because she also traveled to Canada, and these places are at a very high risk of this fungal pathogen that has been identified as a causative agent of central nervous system infection in immunocompetent patients. However, in this case, cryptococcal antigen testing, they came back negative. Another test for cryptococcal or fungal infections. So therefore, on the basis of our clinical presentation, exposure history, and laboratory test results, fungal meningitis seems unlikely. So we are left with the non-infectious causes, the neoplastic, the autoimmune inflammatory, and from the panel, the investigation panel, you can see that this patient is very unlikely that this patient had maybe a tumor from MRI or CT that was done. Although she had, she normally uses non-steroidal anti-inflammatory drugs for migraine, but the exposure to even NSAIDs have been said to be very minimal. So non-infectious causes of meningitis, they are very unlikely. Now, Dr. Muslima mentioned something about CNS lymphoma. I will just quickly touch this. Now, CNS lymphoma, yes, is one of the common causes of lymph node enlargement on imaging studies, maybe as a result of metastasis to the lymph nodes. However, it is more common from the articles that I've gone through in males, that's in ratio 2:1, and in their late 50s or even average age 35 years. This patient is a female and it's also 26-year-old. So that's on one side as is gradually ruling out CNS lymphoma. Then primary CNS lymphoma is commonly seen in immunocompromised patients, most especially HIV patients that are presenting with low CD4 counts. So even though immunocompetent patient might be affected, the mode of presentation as well as laboratory findings in these patients, they are not consistent with CNS lymphoma. Now, I'm left with two, my special considerations. Those are mumps and lymphocytic choriomeningitis virus infection. Now, although the result of the patient CSF analysis were atypical for most viral causes of meningitis, there are two viruses that are associated with profound lymphocytic pleocytosis, and that is mumps virus and lymphocytic choriomeningitis virus. Now, let me start with mumps. Historically, mumps has been a major cause of meningitis. This patient was probably vaccinated against mumps, however, immunity may wane. Mumps infection typically occur during late winter and early spring. Because mumps is transmitted via respiratory droplets or direct contact, it is an highly infectious viral disease. Now, the incubation period is between 15 and 24 days. Thus, this patient would have probably been infected before she traveled. Now, meningitis occur in up to 10% of patients with mumps infection, and it can either precede, follow, or be concurrent with parotid swelling. So if you don't, the fact that you are not seeing parotid swelling, maybe in males, orchitis, mumps orchitis, or mump ophoritis, does not totally rule out mumps infection or mumps meningitis. So it could either precede it, could follow it, it could also be concurrent. So although parotitis may be absent in approximately 50% of cases, so the fact that we don't see doesn't mean the patient cannot have mumps. Patients with mumps meningitis may present with clinically significant lymphocytic pleocytosis in the CSF and a moderately low CSF glucose. Now, the diagnosis can be made by the means of CSF nucleic acid testing, which should be performed in this case. But although I do not think mumps is the most likely cause of the patient's illness, given that she does not appear to have any risk factor for exposure to mumps virus from the history. Now we are left with lymphocytic choriomeningitis virus. Now, among patients in whom meningitis developed, the typical manifestation of infection is similar to what we saw in this patient, and that is a biphasic illness. And while Dr. Ridwan was making his deposition, I was actually I was shaking my head that yes, we have. It's actually, I'm not surprised. So it's actually a biphasic illness, and the characteristic is an influenza-like syndrome followed by a convalescent period of several days before the meningismus will now start. So it's influenza, then everything will go to rest, then we'll now start having meningismus features of meningitis in the patients. So the diagnosis can be established by detection of lymphocytic choriomeningitis virus nucleic acid in the CSF during the acute stage of the illness, or detection of seroconversion to the virus on the basis of antibody testing during the acute and convalescent stages. Now, given the patient clinical presentation, history of exposure to rodents, and CSF profile, that is marked lymphocytic pleocytosis with a moderately low glucose and high protein level, I think lymphocytic choriomeningitis infection is the most likely diagnosis in this case. My verdict, the final diagnosis is actually lymphocytic choriomeningitis virus infection. And a diagnostic test was carried out. The patient's CSF culture came back negative for bacteria, mycobacteria, fungi. Then serologic and CSF testing were negative for arbovirus, including the West Nile virus, Powassan virus, tick-borne encephalitis, Eastern equine encephalitis virus, and also St. Louis encephalitis virus. Now, serum and CSF samples were submitted to the CDC in the United States for measurement of lymphocytic choriomeningitis specific immunoglobulins by means of an ELISA, that's the enzyme-linked immunosorbent assay. And the results came back as the assay was positive for IgM and IgG antibodies. Serum was, IgM was a titer of 1 to 6,400. Then IgG is a titer of 1 to 1,600, which are quite significant. While in the CSF, the IgM and IgG, a titer of 1 to 1,280. This is consistent with recent lymphocytic choriomeningitis virus infection. Now, the viral nucleic acid were not detected in this patient CSF. However, the lumbar puncture was performed 3 weeks after the onset of phase 1 of the influenza-like symptoms. Now, the LCMV nucleic acid testing may detect viral ribosomal nucleic acid in blood or CSF only during the first 2 weeks of after the first symptoms begins. Now, 6 weeks after the lumbar puncture was performed, convalescent LCMV IgM and IgG in the patient's serum were both above what reached titer of 1 to 6,400. This result reflects an increase in IgG to conform with the diagnosis of recent LCMV infection. Now, I won't want to bore us so much with the way it was managed, but just as Dr. Ridwan has said, the treatment or the management of, and also Dr. Alabi, the management of LCMV is actually a supportive kind of treatment. There's nothing special. And I'm very happy to tell you that this patient was actually treated in this way, supportive treatment, and after 3 weeks, she actually got better. I have my references, and I'm going to share the case file with on the assembly pages and also the faculty pages, so that we can have a look. So once again, I want to appreciate everyone who have contributed to this case presentation, and I want to believe that we have learned 1 or 2 things from this case presentation, most especially in trying to rule in and rule out different causes of meningitis. Now, case presentation during my medical school days is one of my favorites. I think it's being done in pediatrics, and I always look forward to it because it's actually a brain jogger. So do I have any contribution from anyone? If you have anything to say, please let me see your hand. So in the absence of that, I would like to appreciate everyone for making it to this multidisciplinary conference. The next edition of virtual assembly will be coming up the ending of March, and we're also going to be looking at something very, very interesting. Once again, thank you, and have a good night rest.